I have the privilege of introducing someone who I think has one of the most wonderful and the most thankless jobs in Washington. I think being the AIDS czar at the White House is extraordinarily important until all of the folks like me, oh, hi, come on, sit down. How are you? 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 So aren't we glad they're all here? We should clap for them, don't you think? But I get to introduce Dr. Grant Colfax. And what I know is that he has almost an impossible job, and he's doing it. What I know is that he has community leaders like me and several other people in this room constantly complaining to him, and he still smiles, and he still says we can come into his office. And so I truly appreciate it, and I know that he is pushing the rock, like Sisyphus, he is pushing that rock up the hill, but we're gonna get it. And so, ladies and gentlemen, our AIDS czar, Dr. Grant Colfax.
Well, thank you, everybody, and welcome to the Super Bowl of HIV/AIDS conferences. So I think, I hope that with the line still going on, I hope we haven't already fully implemented the Affordable Care Act by the time everybody gets their lunch. But I really want to thank Paul for your leadership and NMAC's leadership in our effort to address the epidemic and in our collective effort to implement the National HIV/AIDS Strategy. As you all know, the fourth goal of the National HIV/AIDS Strategy is for a more coordinated and aligned and collective response to the domestic epidemic, recognizing that ongoing federal efforts are necessary but not sufficient, that it takes a collective effort across the nation by people like you and what you do every day to make a difference in improving outcomes for people living with HIV and preventing as many HIV infections as possible. Last year, I had the honor to be here and address the plenary. It's been a long year. It's been a big year. There was an election coming up last year. I think we did pretty well with that. Thank you. I think we did pretty well, and now we are moving forward with continuing to affect real and meaningful change. You'll remember that the National HIV/AIDS Strategy has three main health goals: reducing new HIV infections, improving health outcomes for people living with HIV, and reducing HIV-related health disparities. And in the 3 years since the strategy was released, we've made remarkable scientific advances in terms of how we understand and treat HIV. Now, treatment is recommended for everybody living with HIV, regardless of their stage of disease. That's a big change. Treatment is recommended for everybody. We know that treatment is prevention, that treatment reduces HIV transmission by 96% among people who go on treatment earlier. A huge scientific finding, a huge implication for people living with HIV, people at risk for HIV, and for how we talk about HIV treatment and prevention together. And as many of you know in this room, for the first time, in April of this year, the US Preventive Task Force recommended that everybody between the ages of 15 and 65 gets screened for HIV, gets an HIV test. So really big changes and challenges with regard to our scientific advances and with regard to how we implement these advances on the ground to make a difference in people's lives. On July 15th, on the third anniversary of the strategy, in response to these changes, the President issued an executive order creating the HIV Care Continuum Initiative, which takes into account these advances and also recognizes that in data produced since the strategy was released, data produced by the CDC, we know that we must do better. This is the HIV care continuum. And you see we have a cascade along the care continuum. Nearly a fifth of people living with HIV are undiagnosed, and only 25%, 1 out of 4 people living with HIV in this country has the virus under control. We must do better, We must get that 1 in 4 to 4 in 4. So the executive order called on federal agencies to take a good hard look at what they're doing with regard to their HIV programming and support, and to figure out how to respond to the latest scientific advances to improve outcomes along this continuum. And the federal work group that was formed as a result of the continuum is charged with providing these recommendations to the president within 6 months. We will continue to work with you. We will continue to work with others in the community to get this right. And I'm very happy to say that we will be having several webinars in September where we want input from you, from your communities, about how do we get this right. And we'll be putting up the dates of the webinars after this session. So part of implementation of the national strategy with regard to how we reach these goals is implementation of the Affordable Care Act. What a transformative piece of legislation. What a transformative law. We stand at a moment of history here, and we're in the end zone with regard to beginning implementation. The Affordable Care Act will expand coverage to about 30 million Americans. This includes 9 million Latinos and 7 million African Americans, the populations most affected by HIV in this country. And already millions of Americans have increased health coverage due to the Affordable Care Act. Now in January of 2014, when open enrollment starts, we'll continue to see major changes. There's so many, but one of the main ones I think that we need to continue to talk about and to inform our consumers, our patients, our families, our loved ones, is that because of the Affordable Care Act, insurance companies will not be able to deny coverage based on pre-existing conditions, including HIV. How many of you have had that conversation with people, right? I mean, I'm a provider. I've had conversations. I don't want to get an HIV test because if I'm positive, I'm not going to ever be able to get insurance. That is done in just a few months. Huge, huge stuff. HIV testing will be covered without additional cost sharing in new health plans. So these are transformations, but there will still be gaps. Some people will not be covered by the Affordable Care Act, and some states are not expanding Medicaid yet. And there's also likely to be ongoing need in other areas. 70% of people who are on the Ryan White program, for instance, already have health care coverage, suggesting that the need for Ryan White services will continue even among people who gain health coverage. Also, with more people entering the healthcare system who are either already diagnosed or diagnosed because of HIV testing, there will be an ongoing need to serve these folks. So we'll have, if we reach the goals of the National HIV/AIDS Strategy, as we reach the goals of the National HIV/AIDS Strategy, more people are being diagnosed, more people are ongoing medications, there's going to be an increasing need to expand the capacity to serve the people who are coming into the system. So to meet the goals of the national strategy, we need to realize the synergies that the Affordable Care Act presents, while being mindful of a focus on evidence-based interventions and reaching the populations most affected by HIV. So joining me today to have this conversation are some of the most senior US government leaders, colleagues, and friends who are working together across federal agencies to improve the nation's response to the HIV epidemic. I also want to acknowledge that leadership, our leader from the NIH is here, Dr. Jack Weitzcarver. Jack, can you And as you know, the national strategy calls for a coordinated response across different federal agencies, including the Department of Labor, and I believe Dylan Orr is in the audience as well. He's been one of our main leaders at the Department of Labor with regard to implementing the strategy. Dylan, are you? So now let's talk. Our first panelist is a friend and colleague, Dr. Jonathan Mermin from the CDC, where he's CDC's lead voice on HIV and AIDS. And Jono, thank you for being here today. And I'm going to be asking you and the other panelists the same two questions. What are 3 action steps CDC is taking to get ready for enrollment? And I'll just add, I can repeat the second question because I know you're going to have a great answer to the first one. But just for now so you know what's coming. What aspects of the Affordable Care Act do you think are critical for your grantees and most important with people living with HIV?
Well, thank you, Grant, for your insightful questions, and also Paul for inviting me to USCA. It is the Super Bowl of conferences, and it's really a pleasure to be here and to learn and meet with people. I also wanted to thank you for giving us the questions in advance. And although we were only allowed 2 slides, I made 3, because I wanted to start in partial answer to the first query with a single background slide that shows how the HIV epidemic continues to be a major public health problem in the United States, and one that is growing. Today, about 1.2 million people are living with HIV, and the number of persons living with HIV, shown in red in this slide, has increased 60% in the past 15 years. Each year, there are about 50,000 new infections and about 20,000 deaths among people with HIV, a net increase of about 30,000 people each year. This is good news, since it reflects improved diagnosis, care, and treatment. However, it presents a challenge for prevention, as a stable incidence, shown in blue and yellow on the bottom of the graph, and effective treatment result in an increasing number of people with HIV who have the potential to transmit the virus. The epidemic itself calls out to us that we need to do a better job faster, because the window of opportunity is closing. But this is true at the same time that the theme of this session, the Affordable Care Act, provides us with some of the tools and opportunities to meet the challenges we currently face. So in response to Grant's first question, in this slide I highlighted 3 activities with which CDC is involved that take advantage of some of the changes in the healthcare system, in addition to encouraging our partners to help clients and patients with enrollment in the healthcare marketplace. None of these can be fully understood without appreciating the fact that 2 years ago, HHS HIV treatment guidelines changed to become the most proactive in the world. Antiretroviral therapy is now recommended regardless of CD4 cell count, as Dr. Colfax had emphasized. And this recommendation incorporates both the clinical and the prevention benefits of ART, and cements in writing the recognition that HIV prevention and HIV care are intertwined and synergistic. So the first activity relates to a fiscal year 2014 $40 million budget redirection from Congress that will increase health department and potentially community-based organization capacity for reimbursement and billing of services such as HIV and STD testing, and will increasingly focus CDC funding on evidence-based interventions that will have the highest impact on the epidemic. The second is the Secretary's Minority AIDS Initiative Fund-supported Care and Prevention in the U.S. funding announcement. This is an $11 million a year collaborative pilot program across all HHS agencies, or at least the ones represented here on this podium. And it uses health department surveillance data and personnel, clinic staff, patients, and other organizations connecting each other to ensure optimal testing, linkage, retention, and treatment in 8 different states. And those states were the ones that needed it the most. The third activity is an upcoming comprehensive set of HIV prevention and care recommendations for persons with HIV that were developed jointly by CDC, HRSA, and multiple other agencies and organizations, as well as people living with HIV. And these guidelines explicitly integrate prevention and treatment and take a holistic view of health and prevention. The second question that Grant asked relates to aspects of the Affordable Care Act that are critical for CDC's grantees and people living with HIV. The first is that the Affordable Care Act states that preventive services rated A or B by the U.S. Preventive Services Task Force will be covered with no copay by Medicaid expansion plans and most private insurance plans. This means that HIV screening for people aged 15 to 64 years and more frequent testing of persons at increased risk for HIV, as recently recommended, in alignment with CDC guidelines, will be reimbursed. Our task is now to expand HIV testing to those who need it now that financial barriers are lessened. The second is that behavioral counseling for STD and HIV prevention received a Category B rating by the task force, and that should allow reimbursement for some of the behavioral interventions that are the mainstay of HIV prevention. In relation to CMS, Medicaid's new final rule defines preventive services as services recommended by licensed practitioners, a potential opportunity to expand reimbursement for non-clinical providers. In other words, people who are not doctors or nurses, both inside the healthcare setting and potentially outside of it, such as community-based organizations. And lastly, we're collaboratively working with HRSA and others on an HIV screening measure to submit for meaningful use, and have already positioned several clinical measures for the same. And these measures, which are elected to be used by health clinics and providers, allow an opportunity for both measuring progress on the most important indicators of success, as well as supporting changes in clinical practice. So those were my responses to the questions, and thank you, Grant.
Well, thank you very much, Jono, for that, and really a very complete description in a very short time about the work that CDC is doing. I would just ask if people have follow-up questions to ask Jono or the staff at CDC. They've just been doing a great job of preparing for this change and making sure that we get this right with CDC grantees. So we now have Dr. Laura Cheever from the Health Resource and Services Administration, where she is now the lead coordinator for the Ryan White program. And Laura and I have known each other for many years, and I just want to say it's been a joy to work with her and her leadership at HRSA. HRSA has been fired up and is ready to go and putting stuff out in terms of technical assistance and so forth. So just really excited to have her here today, and she's going to tell you more about the great work they're doing. Dr. Cheever.
Good afternoon. I'm feeling a little bit set up. I was told not to have slides, and Jono got to have two. No one told me to wear a gray suit. I could have been informed, but anyway. And we play baseball in my house. I don't know very much about football either, so any analogies are going to be baseball analogies. To start with, we had two questions, and what are we doing around outreach and enrollment? Well, I can tell you that in the HIV/AIDS Bureau, which I call HAB, in the Health Resources and Services Administration, that ACA and transitioning our grantees towards ACA full implementation has been one of our top priorities, certainly for the last year as we've gotten more information as to exactly what it's going to look like. And that's critically important because the Ryan White program touches over 500,000 people living with HIV in this country. That's over 60% of those people that are diagnosed. So our ability to transition well is going to have a huge impact on people living with HIV. And I've got to tell you that the intersection between Ryan White and ACA is pretty complex. And it's going to be very complex at the national level because really, state to state, it's going to look very different depending on what's going on in your state. So what have we done? Well, I think the most important thing we needed to do was to articulate that intersection between Ryan White and ACA implementation. To do that, we had to partner closely with CMS, and I want to thank Stephen Shaw and all of his colleagues for really helping us understand that intersection. As a result of that, we have over the summer put out 6 different policy notices on Ryan White and some of the changes that are going to occur in terms of interaction with ACA and the ability to buy insurance and premium support and other things that grantees haven't always thought of very much in the past, but certainly we can do in the context of Ryan White. And we put out a particular letter showing how grantees could use their existing Ryan White resources, A, B, C, and D, all the different parts of Ryan White, how they can use those resources to work on outreach and enrollment now. They don't need to wait for any special projects or pots of money that might be coming from CMS. And our grantees have taken that call and have started moving in that direction. Once again, this is not just 2013 in terms of registration, but we're going to need to be enrolling people again and re-enrolling in 14, 15, 16, and beyond. So we're looking for the long haul as well as intensely for this year. As a part of that, what we have done is we have put on 5 webinars to train our grantees in these multiple areas. Once again, partnering closely with CMS. CMS has the lead in HHS for both the expansion of Medicaid and for the exchanges and purchasing insurance through the exchanges. So we need to work closely with them so our grantees can understand what that means to make that transition. And if you did miss those webinars, I'd encourage you to go back and look at them. If you go to the HAB website, we have a page on our website devoted to ACA, and you can click on and review our webinars. I reviewed one of them today because I'm going to be discussing all of these policies today at 2:30. I'd encourage any of you that want to get more information to come to that session. And the webinars are really excellent and actually taught me a couple of things that I need to know for this afternoon. The third thing we've done is we have gotten some special money from the Secretary's Minority AIDS Initiative funds this year to fund one national cooperative agreement that will be providing technical assistance to our grantees on outreach and enrollment. Hopefully that we will get that funded either this week or next week. And they're really going to be looking at best practices across our grantees to make sure that we're sharing successes amongst our grantees as we're learning the best ways to do outreach and enrollment, as well as looking at what the needs are and developing new technical assistance tools that we need to fill in the blank. The second question was really the parts of ACA that I think are going to be most helpful to our grantees and also for people living with HIV. I think by far and away number one for me is the expansion of Medicaid to people that do not need to be disabled. I mean, it was a tough time in HIV where people had HIV infection, but until they were disabled, they did not qualify for Medicaid in most states. A majority of the uninsured that are getting Ryan White services have less than 100% federal poverty, which means that in states that expand Medicaid, they will be on Medicaid, and that'll be huge for them. The expansion of Medicaid means that they'll have access to services that aren't available through Ryan White per our statute, services like hospitalizations, ER visits, surgeries that they need that aren't part of the Ryan White program. In addition, in a lot of places, services that could be paid for through Ryan White, like specialty services if someone needs a colonoscopy or an EGD, or someone has hepatitis C and needs to see a hepatitis C specialist, that could be paid for through Ryan White, but in a lot of places, the Ryan White dollars just don't go that far. So it's not available to people, and now it will be because they'll be insured. So that by far is the biggest thing for me. The second thing is the availability of insurance for people that have pre-existing conditions. In the past, people that potentially would have had means to get insurance on their own couldn't because it was denied because they had HIV infection. So Ryan White came in and helped pay for things for that patient because they didn't have any other ability to pay. Now those people will be able to access insurance through the exchanges. In addition, in places where Medicaid is not expanding, the Ryan White providers can potentially purchase insurance for their clients, giving them access to all those other things we've talked about, like hospitalizations and emergency room visits, because they will have access to buy insurance for someone who has a pre-existing condition. So we, in our policy notices, have encouraged our grantees to look to see when buying insurance is more cost-effective than providing the services themselves through Ryan White. What both of those things mean is if the patients increase getting insurance and we can buy insurance for people more cheaply than we can provide services, it means there's more money left over in the Ryan White program to provide all of those unbillable services that are so important for getting people to be engaged in care and linked to care. Things like navigation from your testing site into care and helping people in care stay in care, providing treatment education services, counseling around medications and adherence, all those things that we provide in Ryan White that aren't exactly billable in a lot of insurance plans, there'll be more funding to provide those things. And we have an example in Massachusetts where they've had expanded insurance for some number of years. They've spent their Ryan White dollars differently, and they've actually changed the course of their epidemic. So my hope is with the expansion of insurance in this country, using Ryan White dollars differently, that grantees will be able to really change the course of the epidemic. Thank you.
Thank you very much for that, Dr. Cheever, and really appreciate your points made and the ongoing conversations and the fact that HRSA is really committed to continuing to work with the community through trainings and webinars and making those accessible to all of you in the room and also to your stakeholders and most importantly, the people we serve living with HIV. So my guess is, like many of you, I was more familiar with the work that the CDC does and HRSA does and sort of had more interactions and relationships with them in the public health department where I previously worked. One of the main players in implementation of the Affordable Care Act is CMS. And in order for us to get this right for people at risk and living with HIV, CMS will play a critical leadership role. And that's why Dr. Stephen Shah is here, the Chief Medical Officer at the Center for Medicaid and CHIP. And you know, in DC, there are a lot of smart people working on this. I have to say, Dr. Shah is one of the smartest people working on this. So it's just really my pleasure to bring up Dr. Stephen Shah to talk about what he's doing and what his team is doing with regard to the Affordable Care Act and HIV with regard to the National HIV/AIDS Strategy. Dr. Shah.
Thanks so much for that overly nice introduction. It's hard being the third panelist on a federal panel because to a large degree, I think what I have to talk to you about is basically everything Jono and Laura just talked about. But I'll say a few things, which is, and the first overview piece in terms of what we're doing to prepare for the ACA ACA expansions and transition. You know, the list of tasks would fill this wall, and we have Gantt charts and flow charts that would in fact fill this wall. It's 22 days till open enrollment, not that we're counting, but we're very hard at work to ensure that this transition happens as smoothly as possible. So rather than go through the litany of activities that we're involved with, I think there are three key questions that I think we need to continue to ask ourselves at CMS in partnership with all of you, in a partnership with our folks on the stage. And let me just say on that front, we are collaborating more strongly than ever, I would say, in terms of trying to ensure that we don't have these gaps between the agencies, that we have a unified vision and flow towards our approach toward these activities. I talk to these guys constantly in terms of how we're trying to approach these problems. What are you hearing from your grantees? What does that mean for our implications and our programs? And I don't take that from a standpoint of being a good partner. This is about, from our program standpoint, addressing the high needs of an important group of beneficiaries and how do we best do that and draw from the knowledge of our partners around administration. It's a key central point and one we take very seriously and we've been very invested and involved with for at least my time at the agency. But the three questions that we continue to ask ourselves is first, how are we going to ensure that everyone's enrolled? And on that front, I would make a plea to everyone in this room to continue thinking about that calendar, that 22 days till open enrollment and that January 1 date. You all face these beneficiaries, you see them. We need your help. We need your help to ensure that they get on the programs, that they get the insurance and the coverage they need, that they're really seen in terms of the system. You guys know those systems and what's happening in your state and where those pockets of beneficiaries are better than anybody. And I think my first plea is just a request for all of you to continue to work with your partners in your state, whether they be the exchanges or the Medicaid program, the patient navigators, all the tools we've made available to try and ensure that we have that transition onto full enrollment. It's critical and we're asking for your help and we appreciate the work that you're doing already to date. We know many of you are fully engaged in that. So the first is how do we really think about getting them onto our programs as we know we can. The second is really in this early phase, how do we think about ensuring that they get what they need from a benefit standpoint? How do we ensure that they're getting the drugs they need? How do we ensure they're seeing the right providers? How do we ensure they have the right benefit package? How do we ensure that our Medicaid benefits are meeting this new world and the new challenges? How do we negotiate between Medicaid and EHB? I'm not going to stand here and say we have all those problems cracked. But I am going to say here that we have a firm commitment to continuing to work on these in an aggressive fashion, to listen to you all, to hear what we're hearing from the states, continue to hear from our partners in terms of what kinds of lessons we're hearing, and act aggressively in terms of responding to those problems where they may arise. I think we're hopeful and confident that there will be a smooth transition for many, but we recognize that we need to continue to think about the casework that's needed to ensure that all beneficiaries get the kind of care that they need in the new world. Those are sort of two of the early questions in terms of how do we think about this early on in 2014. The promise of ACA was much more than about getting insurance. It was much more than about getting benefits. It was ultimately, and that care cascade slide comes to my mind a lot when we talk about this. The ACA was about how do we fundamentally change the way we're taking care of our beneficiaries? How do we fundamentally improve it? When I look at that care cascade slide, it says to me, our status quo isn't good enough. It shouldn't be good enough for us just to say, let's go into 2014 and make sure we don't lose anybody. That shouldn't be our goal. It should be about how can we really take that foundation of Medicaid coverage, learn from the successes of Ryan White and CDC and all of your work out there, put that into a delivery system reform, combine those ingredients to create a system that truly changes the course of this epidemic in this country. That's what we're really interested in from the CMS perspective, and I think we have a real promise and opportunity to do that if we work together. I can't commit to you that this is going to be something that happens January 1. It's not. I think we are, in fact, very focused, and I think rightly so, in terms of triaging our challenges, in terms of getting our beneficiaries standed up in the system and getting them into flow in that system. But I can tell you that there isn't a state in the country that isn't thinking about how do we really improve care for these beneficiaries once we have them on our systems. Those conversations are happening now with our state partners. They're going to continue, and they're going to get more active, and we need your help in those conversations, not only from the state perspective, but to learn from all of you in terms of what's worked. What are those models that we really should be building upon into that transition into 2014 and beyond? What's that long-term vision for really changing the flow and taking those real core benefits and adding them to a care delivery system that's truly meeting the needs of the beneficiaries? That's what we're focused on in terms of trying to think about that. So it's not always a public conversation. Some of these pieces are happening in terms of how do we unpack this? How can we really think about using our tools and authorities in a different and perhaps more aggressive manner? And I think one case in point, I think, is something Jono mentioned, which is the issue about the preventive care benefits. We heard for a long time from many community-based organizations that we have a great program. It's evidence-based. It's really meeting the needs of our beneficiaries, and you, Medicaid, won't pay for it. So we went back inside and said, okay, well, we do have this regulatory barrier that says we'll only pay for licensed personnel, but we do have this evidence we can't ignore, that there are proven models out there to think about prevention provided by providers who may not have a license but are otherwise qualified. And that's what led to a lot of the preliminary work and finally to the final rule that went out in July. I think it's a symbol. It is not all of what we're trying to do, but it's a symbol of how we are trying to be responsive to the lessons that we're hearing from the field in terms of what's working and not working, and how are we really promoting the best evidence-based care, and how are we sometimes a barrier, and continuing to move forward in terms of iterating our own ability to change those lessons in terms of as we move forward. The last thing I want to mention in this frame is that we have a number of authorities in terms of delivery reform, whether it's health homes, and many of you know about that, and there are 4 health homes, 10,000 beneficiaries in health homes focused on people with HIV and AIDS. We have new flexibilities in terms of what we call our integrated care models. We're putting out a whole bunch of new TA. We just put out an informational bulletin on super utilizers, this idea of hot spotters. I can't think of something more germane to the super utilizers than the beneficiaries that you serve. So there's a whole range of both TA and authorities and financing in terms of some of our waivers and other authorities. The last thing with my last 10 seconds, I realized, is that second piece of the question, which is really how are we thinking about the ACA moving forward. I think I've talked a lot about that, but just one final point to make, which is, and I think Laura hit upon this as well, which is that there's nothing more important than full insurance coverage. I'm a primary care doc. I see people with HIV, and a lot of them have been uninsured. I think I'm in DC, so we're moving to a situation where that's not true anymore. That change has been really a paradigm shift for the beneficiaries that I see in my clinic. We expect to see that paradigm shift around the country. So it's just an urge that we're not going to just cover the children. We will cover the parents. We're not just going to cover people with their health who's so deteriorated that they've qualified for SSI. We will cover people with disabilities, and before they get to the point where the health's deteriorated. We're not going to just cover pregnant women. We will cover women who aren't pregnant as well. I think this idea of moving beyond the categorical nature of Medicaid expansion to a vision where we'll treat the people and address their needs regardless of what our arcane category they fit in. That's the real vision that the Medicaid expansion really holds. So I urge you all to continue those conversations in your own states. Thank you. And to continue to engage in terms of thinking and partnering with all of us to think about how do we really move that vision into reality. Thank you.
Well, thank you very much, Dr. Cha. I very much appreciate those words of wisdom. So a few minutes before I got up to start this session, I got a call from a close friend who wanted to talk to me about another friend who has a chronic condition and also has bipolar disorder, and is currently having a manic episode and has gone off for meds for her other chronic condition. And I think this really calls into focus the issue of mental health with regard to management of HIV, management of other chronic diseases, and the barriers that mental health issues can present to health and wellness overall. Certainly, the National HIV/AIDS Strategy calls for a focus not only on mental health, but also on substance abuse issues, which we know are so consistently intertwined in many of our lives. So it's my pleasure to bring to the stage Mr. Michael Duffy from SAMHSA to talk about how SAMHSA is addressing the intersection of substance use and mental health with regard to HIV/AIDS and implementation of the Affordable Care Act. So, Mr. Duffy, please. Thank you.
I do, first of all, want to acknowledge that our medical director, Dr. Ellie McCants-Katz, could not be here, and so I'm here on her behalf, and I will leave it to you to determine who's the better looking. I was asked to share on a personal note some of my experiences here in the state of Louisiana prior to working with SAMHSA as their SAMHSA regional administrator. I had the opportunity and privilege of facilitating one of the first HIV/AIDS support groups in the mid-'80s here in the northern part of the state. It was that experience that has embedded in my heart a desire to make sure that we do all that we can in working with HIV-infected folks who have accompanying behavioral health conditions. I then had an opportunity to serve under the last 3 governors in this state as the state director for the Office for Addictive Disorders, and now as the SAMHSA regional administrator working with 5 states, recognize and realize all too well the challenges that comorbid behavioral health conditions and HIV present to our healthcare system in general. You know, it's SAMHSA's belief and understanding that behavioral health is essential to all health, and most especially for the health of those with HIV, that we now have, for the first time in the history of SAMHSA, a regional presence throughout this country within Health and Human Services. And you'll see the slide of the mugshots of the 10 of us who represent SAMHSA within HHS. And I want to encourage you to make those connections and let us know if there are ways that we can in turn support you in the work that you're doing. I'd also like to bring to your attention one of the, I believe, most important pieces that SAMHSA has to contribute to our work in moving forward with the Affordable Care Act. We just recently released, as a result of some work that we've been doing with 5 national coalitions, and if you think about the coalitions that I'm going to mention, they're all coalitions that I think you'll find that we have common partnerships around. One has to do with mental health and substance abuse providers across the country, prevention coalitions. We also work very closely with the homeless coalitions, as well as the criminal justice population and those individuals in recovery from mental health and substance abuse. And as a result of this work, we've touched over 40 national coalitions, but recognize very clearly that a lot of folks don't have at their fingertips the resources necessary to understand all the ramifications of the Affordable Care Act. So we've partnered with our colleagues at CMS and put together a toolkit which offers the opportunity for local coalitions and stakeholders to view a 30-minute video, which then has tied to it, and it walks you through the 119 different resources. Everything from PowerPoints to widgets to help make certain that at the local community and stakeholder level, folks have those resources available to them. You know, we started this session today with a reminder that we have this historical moment in time to change the lives of millions of people in our country. But I would suggest to you that all of our federal partnerships and all of the work that we're doing, the work that's being done at the state level, absent individuals and communities and stakeholders across this country, and each of you in this room will never accomplish the goal. So I'm asking you to give consideration to what one of us alone might not be able to do, all of us together can. Thank you.
Thank you very much for those remarks. And when we think about the HIV care continuum, we see those drop-offs, especially I think between the linkage to care and the engagement to care piece. One of the questions there is, what is the intersection of behavioral health? What is the intersection of substance use treatment to really improve those outcomes? And just again, I don't know if we're going to get the slide about the webinars coming up. So it's coming up. It looks like they're trying to make it work. Anyway, they will put up a slide about the upcoming webinars with regard to getting input from all of you on the working group's work with regard to the Care Continuum Initiative. I think in some of these cases, in terms of dealing with so many complex issues, when you take a step back and you say, okay, when somebody comes and asks me about how do I learn more about the Affordable Care Act, where do I start? There's so much information out there. In some cases, it's very complex, and it's hard to even sometimes know where to begin. And I would just ask you to give a simple answer, which is healthcare.gov. If you haven't looked at it for a while, it's been updated. It's easy to use. It's easy to find what you need. It's easy to go to the level you need to go to find the right information. So if you're asked that question, or if you want to find out more, go to healthcare.gov. And I just want to thank our federal colleagues with regard to showing the synergies that are occurring with implementation of the Affordable Care Act, ongoing implementation of the National HIV/AIDS Strategy. As you know, the strategy calls for a more coordinated inter- and intra-agency response. And we all are very committed to moving forward together with all of you in this room to get it right for people living with HIV, to realize the goal of the President's vision of an AIDS-free generation. Thank you very much.
Thank you to all of our federal partners for today's presentation. Ladies and gentlemen, it's time for dessert in the exhibit hall. Dessert is being served at 2 o'clock in the exhibit hall. Seminars begin at 2:30. This evening, there's a welcome reception from 6 to 7:30 as well in the exhibit hall. Have a great afternoon. Thank you.